Sure. So shorter is better is a nice catchphrase. I think the more appropriate term is shorter is just as effective as longer therapy. In the past couple of years, we've had more studies coming out, not looking at a specific drug or a specific indication, but looking at, all drugs or collection of drugs, a particular drug class being used for a particular infection. The newest update of the HAP and the VAP guidelines. We went from 2005, 2006, HAP-VAP was saying, okay, you can do 7 to 8 days of therapy unless they're non-fermenters, so things like Pseudomonas, Stenotrophomonas, Acinetobacter. For those, well, maybe we can treat those for 2 weeks. The 2016 version, they said, you know what, no, 7 days for all patients. It doesn't matter what organism is causing their HAP or VAP. They went back and they did their own analysis and they found that there was no difference in relapse or mortality. So why shouldn't we treat for shorter in these patients? Additionally, febrile neutropenia, we've had a number of studies. We've had the How Long study, we've had the antibiostop study that have been looking at, rather than waiting for patients who are febrile neutropenic and don't have an identifiable source of infection, do we need to wait until they have neutrophil recovery, which can be weeks or months? Can we treat them until they're afebrile for 2 days, for 3 days, regardless of ANC, and then peel back? And studies are showing that they probably do just as fine as the ones that we have for longer durations. Just last week, there was an article that was released looking at male patients with UTIs or pyelo. How long are we treating them? And that study concluded that 7 days is just as good as longer.